Um, yes, thank you very much, Team Echo. While we continue to see advances in cancer diagnosis and treatment, many patients across Africa do not significantly.
Jessica, you're on mute.
Do not significantly.
Hello and welcome as we
sorry.
give a minute.
Do not benefit from this, and this might be because of issues of access. In today's session, we will be talking about how these new interventions can help increase cancer treatment in our African setting. So Team Echo, once you're ready, we can start with our first presenter. So as we continue to wait for our first presenter to dial in, Mr. Mapelo, I believe today's discussion will be rich, as I think as all of us, as we work in the health system with limited resources, this is a topic where we can talk about how implementation science can best help our system. And today we have two presenters. We have Mr. Mapelo and also we have Dr. Nakaganda. These are lead in their own fields, and today they will be sharing with us experiences and the work that they are doing. Mr. Mapelo will share with us a case presentation, and Dr. Nakaganda will share a didactic presentation. So please, if you have any questions, do share them in the chat, and we will get to them. You're encouraged to share as many questions as you can through the chat. And during the last session where we have our question and answers, we can get back to them. Thank you.
So Mapelo is in.
Yeah, good afternoon, good evening, good morning, Jambo. It's a pleasure to be here today. Thank you so much, Sarah, for starting us off. I had a little trouble joining in, but I'm glad I'm here now. I had shared my slides with Charles. I don't know if, Charles, you're able to run them for me. And as Charles does that, I'd like to just make an introduction. My name is Mapelo, Elo Mapelo, from the Marx Foundation. I have had a long history with KENCO, where I have served in the board of KENCO from 2019 up to last year, 2025, where I retired after serving as secretary and chairman of the board in 2 terms of 3 years each. I've also worked as the chair of Hands of Kenya. It's a member, an organization that is a member of KENCO, a patient support group, and a close affiliate of the Marx Foundation that I now work for. I started working with the Marx Foundation just some 2 years ago. Today's presentation, I'll just be highlighting on the work that we have been doing with the Marx Foundation, which squarely sits on this theme of the day, the new interventions to increase cancer treatment in Africa. So thank you, Charles. I can see the slides are there. You can run the slides. So I'm the program coordinator for Kenya for the work that the Marx Foundation does. The Marx Foundation is an international organization that has activity in at least 83 countries around the world, Kenya being one of them, together with almost about another 20 in Africa. We have activities in provision of cancer treatment, majorly CML treatment, which is where we started some 25 years ago. Now we have fairly wide range of the cancer treatments available over the Max Access platform. The Max, the vision is a world where all people can access high-impact medicines, where geography is not destiny, and where everyone can strive for health with dignity and hope. And this especially considering our, resource limited places like Kenya becomes a lifeline to thousands of patients who get treatment from the Max Foundation, which are donated and, of course, are made accessible through a program we call the Max Access Solution. Next. So, and I, just for this discussion today, I just want to take the perspective of the access gap and how we are addressing this access gap. Oncology in Africa faces dual crisis, one of which is the rising burden on uncommunicable diseases, of course, including cancer, and of course, compounded by systemic barriers to care. And I know you've had these discussions in the past on the kind of challenges that we experience, which are systemic barriers, rising incidence of hematological malignancies, high financial toxicity, which is especially brutal for people in this part of the world, and of course fragmented referral networks and logistical hurdles. These are some of the main reasons that the Max decided to have activities in Kenya, especially because hematological malignancies were seen as rare cancers. There weren't a lot of support from the insurance companies and also from the government programs to take care of hematological malignancies. Blood cancers were left out when breast cancer was being planned for. Cervical cancer treatments were being built. The programs were being built. There weren't a lot of investment in blood cancers, and so the Max Foundation came in to try and address some of those challenges. And the Max Foundation believes, like I say, geography is not destiny, so that anybody from any part of the world should be able to have access to the highest available treatment. Next. I have arranged this discussion today into 4 pillars, and one of the pillars is dismantling financial toxicity. Like I said, that's one of the areas that we realize is a huge area of need, and has been one of the focus points for the Max Foundation's work in Kenya and generally in Africa and the world. Next. So I just had a conversation with my colleagues from Nairobi Hospital, and I picked Nairobi Hospital because that's one area, or the one hospital where the Max Foundation work has been happening, and we've been working closely with the community, the healthcare community in Nairobi Hospital over the last 20 odd years to try and address this issue. So one of the clinicians there did a survey and realized that there is a huge impact of the program as far as patient care is concerned. And he realized that among the Max enrolled patients, the adherence rate 90% and over, while other people who do not have that kind of supported access program, the adherence rate is just about half of it. The contrast between program beneficiaries and non-beneficiaries stark and clinically significant. That's what they realize. And so the patients enrolled in the MASS program demonstrate markedly superior adherence profiles characterized by consistent attendance at appointments, predictable refill patterns, and stable hematological indices during routine monitoring. Because one of the biggest toxicities has been lifted. The fact that they are able to access these medicines and they are not going to be required to pay for them removes that huge barrier and that huge headache that they have, which is affording the medicine, and that makes it easier for them to focus on other things. Patients who are compelled to procure medication out of pocket present with interruptions in therapy, often several weeks duration, corresponding directly with periods of financial hardship. Sometimes when they're not able to afford the medicines, they're not able to continue with treatment, and they keep interrupting treatment, thereby affecting adherence, and that's why the adherence rates are so markedly different. This is just to underscore the impact of this access program, what it does, and the kind of impact it also has, not only on the patients, but also on the healthcare teams. Charles? So this, like I said, is the power of the MASS integration, where we have reliable supply and QC, which ensures consistent TKI therapy, the tyrosine kinase inhibitors, which have been made available over the last 2 decades, preventing disease progression to blast crisis. Normally, when a CML case is not treated or is not properly treated, it usually progresses to blast crisis in about 3 to 5 years. But we've seen people who've been on treatment for really long, 20 years, 15 years, because of availability of this medicine. And another very key aspect of it is that the Marks Foundation, through its various programs, ensures quality control, making sure that the medicines arrive to patient at the best possible quality. I know we have issues with quality in this country. Just today I saw that the Farmers in Poisons Board has issued a memo about one of the breast cancer medicines that has been found to contain toxic ingredients. One of the benefits we have in working with the Marks Foundation is because we have a quality control program that ensures that whatever gets to the patient is of proven quality and has been made, has undergone all the necessary tests to achieve that. Another factor is the patient navigation, that clinicians shift from logistic problem solving to therapeutic and existential guidance. The doctors know that there is available treatment and it is going to be affordable to the patient. Therefore, they just focus on directing the patient towards the treatment, and they don't have to how to haggle with the patient about how you're going to afford your treatment, how you're going to raise your money, how you're going to ensure that you get these medicines, because the medicines are already there. And so it reduces this distress among the clinician by providing the ability to prescribe with confidence. Many a times the doctors say, when someone has been diagnosed with CML, for example, and I'm just singling out CML because it's a program that has been running over the years. But like I said, we have various other programs, and 2 years ago we started a breast cancer program, which we are still registering people for. But for this CML that has been there for 2 decades, most of when a patient is diagnosed with it, the doctors sometimes will tell them that they actually have the good cancer. Not that any cancer is good, but because this one has already an established a care pathway that is both available and effective. So because of that, then it reduces a lot of stress on the doctor's part and other clinicians in handling patients who are undergoing this treatment. Next. The other pillar, and this is very unique to the Max Foundation, is the last mile. We have a program that helps to remove the transport barrier to the patients. Life-saving treatment requires a physical presence of the patient at the facility. For many, the cost of travel is greater barrier than the medicine itself. So the Last Mile program provides transport grants and completes the circle of care for vulnerable populations, ensuring continuity. 2 years ago, the Max Foundation started this program, the Last Mile program, where it provides transport support for patients undergoing this treatment. And this is because this treatment was not available across the country. It was just in Nairobi and a few cities. So it became a bit of a challenge for patients to access the treatment facility. Despite the fact that there is free treatment available, they were not able to get to the treatment facilities. So the Max Foundation started this program that provides transport support to the patients. And over the last 2 years, we've had about almost 200 patients who've been supported with transport who are in the Max Foundation program. And over 500,000 shillings has been spent on that, which has really improved the outcomes on so many of these patients. And as we continue, we keep identifying barriers and keep identifying ways to solve these challenges to make sure that the patients are able to afford treatment and have it as effectively as possible. Next. So the other pillar is grassroots innovation, and this like I said, I work with Hands of Kenya. We worked closely with Hands of Kenya to provide a structured support system. Hands of Kenya, like I said, is a patient-led support group, and working with Max Foundation, we are able to have education sessions where the patients are, exposed to more information about their condition, about the disease, about the medicines, and they are able to understand how the care is done, and they are able to understand how to deal with the adverse events and other side effects that may come from the treatment that they're going through. We are also able to enforce peer counseling session, psychosocial care, where we have patients who share their coping strategy. They are able to empower each other. They are able to encourage each other, which is an extremely important part of the treatment, because then it helps someone know that they are not in this journey alone. They are able to interact with others who are going through the same journey, and therefore they are able to improve the outcomes. Because they are able to compare notes with other patients who are going through the same journey. And we've also had innovative educational tools, and we've even worked with Kenco to help develop material for information, education, and communication. We have community engagement sessions where we are able to interact and help patients able to share and compare their situations with others, which is a good thing in psychosocial support. And also, of course, we have a vibrant WhatsApp group where people are able to share and interact and even get information about their condition. So because of all that, and working with Hands of Kenya on that, we've seen a lot of improvement in outcomes from many patients who are going through this program. Next, Charles. So this, I just put this one here because it's actually the core of the work that the Max Foundation does: governance and visibility. Remember, just the other day, I think some days ago, I think it was last week, we learned that there are quite a number of cancer medicines that were reported damaged or expired, amounting to over 1 billion shillings at KEMSA. And one of the things that we've done at the Max Foundation, and I'm proud of that, is that we have this visibility. We are able to see end-to-end logistics. We closely manage the logistics. We are able to see which patients are using what medicines. We have real-time access to the data of the patients, and that has helped us to not only avoid damages and wastage through expiries, but also they've helped us to be able to do quantification and optimize that for our ordering and ensuring that our inventory is up to date. That itself has made it possible for us to have close to 100% medication utilization, where we have very little, if any, being wasted, and we also have very few days of out of stock, if any, because most of the time we are optimally stocked. So making that possible has improved utilization, reducing wastage, and of course making it possible for the donors to also continue trusting the process and making products available, and even attracting more donors to making this program bigger and wider. Currently, the Max Foundation, the programs that are running in this country are from about 5 different pharma companies, and across Africa there are probably about 6 or 7 pharma companies that give us treatment for various cancers. We currently have about 11 different molecules in the program. We just started with one 20 years ago, but now it has expanded to 11. And going forward, we are looking to expanding that more. Like I said, we've started a breast cancer program, which currently has about 350 patients, offering treatment for HER2 negative and hormone positive advanced and metastatic breast cancer. And we hope to expand that. Probably even in future we might be adding more products in the program. Next. So as I conclude, I just want to say that ensuring that hold on just a minute. So ensuring that we are able to deal with the various cancer treatments, and making sure that we have these new interventions in ensuring access has been a big responsibility for the Max Foundation, but it has only been made possible because of the partnerships that we have between the Max Foundation, the pharma community that provides the medicines for free, working closely with the governments to ensure that all levies and duties have been waived to make sure that the treatment is available free of charge to the patients, and also participating hospitals to make sure that they are able to see the patients and provide treatment to them. That has been the secret of the success of the program that I work for, the Max Foundation. So thank you. In case of any questions, I'm more than glad to respond to.
Thank you very much, Mr. Mapelu. Thank you very much for that great and insightful presentation, grounding it in both the patient system and also realities surrounding access to cancer treatment. So please reserve your questions. Let us finish all the 2 presentations, then we can get back to questions and answers. So now we are going to move to our second presenter. Dr. Annette Nakaganda is our second presenter. So Dr. Nakaganda, she's a leading oncology and global health professional, currently serving as the country focal point for the Access to Oncology Medicine, or ATOM, Coalition Initiative. Dr. Nakaganda has extensive experience in cancer control, more than 20 years, looking at health system strengthening and advancing equitable access to oncology. We are honored to have her here with us today. Please, Dr. Nakaganda, you're welcome.
Yeah, thank you, sir, and thank you all for attending. Sarah, can you hear me very well? Thank you. So I know good afternoon in Africa, and it could be good morning to all in diaspora, and thank you very much for the opportunity to be here. It's really a pleasure to meet you all, the colleagues of Cancer Echo again, and of course key partners, to discuss how the Access to Oncology Medicine initiative is working to improve access to cancer medicines and diagnostics. So today I'm going to give a brief overview of what is ATOM, what ATOM does, and how it works within countries. But overall, the goal is simple: to support countries in ensuring that people access cancer medicines and safe medicines, affordable, and of course, effective treatment now and in the long term. So what is ATOM? It is a UICC, Union for International Cancer Control-led initiative to improve access to critical cancer medicines and diagnostics in low middle income countries. What ATOM really does is that the Access to Oncology Medicine initiative, in brief, we call it ATOM Coalition, as I said, is a global initiative, and it is led by UICC. And it is aimed at improving availability and appropriate use of cancer medicines and diagnostics in low and middle income countries. The initiative focuses on high incidence cancers that contribute significantly to the cancer burden in low and middle income countries, including breast cancer, lung cancer, colorectal cancer, prostate, cervix, and childhood cancers. Importantly, the ATOM is not only about increasing access to medicines, but also ensuring their appropriate and sustainable use through strengthened health systems, as we shall see, diagnostic capacity, financing mechanisms, workforce capacity building, and of course, country-led implementation approaches. And the coalition supports, access to a range of priority cancer medicines, including generic, biosimilar, and innovative cancer medicines. Currently, the initiative includes an initial group of 46 low-middle income countries across different regions globally, with several countries already engaged in capacity strengthening and implementation activities, as we shall see. So what is the problem? As you may all know, currently, based on the global can data in 2022, about 9.7 million people, die from cancer worldwide, with nearly 70% of these cancer deaths occurring in low middle income countries. Unfortunately, this burden is expected to continue rising due to population growth, as you may know, aging populations, and increasing exposure to cancer risk factors. One of the major challenges now is limited access to essential cancer medicines. Some of you may know less than half of the World Health Organization essential medicines for cancer were available, or are available in many low middle income countries, settings, significantly affecting treatment outcomes and survival outcomes. So access to medicines is really still a key priority for World Health Organization, and sustainable long-term solutions now are urgently needed. However, many countries continue to face challenges related to equitable delivery of cancer care, which we all know. So the key barriers here is that there are multiple interconnected barriers that limit access to cancer medicines. Sometimes you wonder which button to press in our setting, and these challenges go far beyond medicine availability. I've tested this in Uganda myself. First, many countries face broader health systems challenges, including finance limitations, regulatory bottlenecks, political and logistical constraints, and shortages of trained health workers. In some settings, there is also limited access to diagnostics, even if you have the medicines. And of course, supportive treatments needed for effective cancer care outcomes. Of course, fragmented supply chains further affect consistency, availability of cancer medicines. The second challenge is that there are so many stakeholders involved in cancer care, as you may all know. One person was saying it is one of the social sciences they have ever seen, is cancer care, and access to medicines. So often with different priorities and objectives. These include stakeholders, the patients, the Ministry of Health, the healthcare providers, World Health Organization, civil society organizations, pharmaceutical companies, procurement agencies, supply chain actors. Aligning these different stakeholders around common goals can be very complex, but very essential. And the third challenge is access to both generic and innovative cancer medicines remains difficult in low middle-income countries. Small-scale programs and donations, as you know, have limited sustainability, particularly in a very fragile health system or systems and smaller markets like for us. In addition, lower patient volumes sometimes and limited forecasting abilities and capacities can make procurement and long-term planning more challenging. So the pressing need for ATOM action now is that despite the global attention, these gaps still persist today, driven by not only limited access to medicines, but also by challenges across the whole cancer control continuum, challenges to do with diagnostics, financing, and health systems capacity, underscoring the continued relevance and urgent interventions like the ATOM Coalition. So addressing these barriers, therefore, requires coordinated multi-stakeholder and country-led approaches that strengthen not only medicine access, but the broader system needed to deliver quality cancer care forever, sustainably. So what I forgot is that the ATOM, I said it consists now of 46 countries. But now what I want to do, the ATOM Coalition approach, I know people are asking. The ATOM Coalition is built around 3 interconnected core pillars that support countries in strengthening equitable access to cancer medicines and diagnostics. The first pillar focuses on medicine and diagnostic access, supporting countries to improve availability and appropriate use of quality-assured cancer medicines and diagnostics through sustainable access pathways, which we shall see in the next slide. The second pillar is capacity strengthening. This recognizes that access to medicine alone is not enough, honestly. Countries also need to build strong health systems. They need trained health workers. They need diagnostic capacity. They need, for example, clinical protocols. They need, for example, research capacities to test innovative medicines. And of course, systems to safely and effectively use these cancer medicines. And the third pillar focuses on, of course, healthy financing, supporting countries to identify, again, sustainable financing approaches for cancer care and improve affordability, as you all know, and long-term access to treatment. So the first pathway in detail, which is medicine and diagnostic pathways. This slide briefly summarizes the first pillar of ATOM Coalition, which focuses on strengthening access pathways for cancer medicines and diagnostics. And one important pathway is licensing, led by Medicines Patent Pool, which you may all know, which supports the manufacture and distribution of high-quality, affordable generic versions of patented innovative cancer medicines. Another way is the indirect commercialization, where pharmaceutical companies help bring quality-assured cancer medicines to countries where they may not yet have a direct commercial presence. This helps expand availability in our underserved regions. Also, the coalition also supports uses the NCD Connect. Some of you may know it. It is a digital procurement platform led by the IDA Foundation that helps countries procure cancer medicines and diagnostics that are safe, more safely, efficiently, and in most cases at a lower cost. And of course, as Elo has presented, the previous speaker, humanitarian donation pathways are used to support access to cancer medicines as well, and the ATOM Coalition for patients and countries with urgent needs, particularly where immediate access gaps exist. So the ATOM priority list of medicines, 65 medicines spanning the 6 most common cancers were developed from different guidelines, including the WHO essential medicine list, and to ensure efficacy, line of therapy, biomarker frequency, and of course across different cancers. And the purpose, as I said, is to strengthen country engagement using the list to systematically identify gaps, priorities, and capacity strengthening. So still on the pathway for medicines and diagnostics, through different access pathways, as I explained, country can access, as I said, country-assured medicines, generics and biosimilars, innovative medicines, diagnostics, and medical devices. For Uganda, actually, we are privileged. This currently includes more than 30 medicines in over 70 formulations. This covers cytotoxic chemotherapy, hormonal therapies, immunomodulators, and targeted therapies like imatinib, nilotinib, nivolumab, rituximab, trastuzumab, and so many others. And the ATOM Coalition also supports access to more than 10 diagnostics and devices, including HPV and breast cancer tests, imaging, equipment, and laboratory consumables. So we work with innovative companies that are involved, like BMS, Cepheid, Novartis, Pfizer, Takeda, and generic companies, so many others. I will show them to you in the next slides. Then the pillar of capacity strengthening. The ATOM Coalition works with healthy ministries, technical agencies in the country, regional collaborators, ATOM Coalition partners, and of course UICC members to address long-standing barriers to healthy systems that can limit actually access to quality cancer medicines. And they hope into country-led actions, coordinate these resources and expertise. All this capacity strengthening work is country-led and tailored to local needs. As I will show you, the process starts with the Ministry of Health signing an MOU with the Union for International Cancer Control, involving, and Ministry of Health involves other stakeholders such as cancer hospitals, non-government organizations, patient groups, and it leads an assessment, country-led assessment, to identify where systems can be improved. As I said, there are so many things that are done in silos. So we start with the country identify gaps, set clear priorities, and design projects that will address those gaps. And of course, this is not left to the countries alone. We get expertise from global technical partners, so that we create practical and lasting solutions from people that have tested this. So the capacity strengthening is across these 4 major areas, which we have regulatory affairs, supply chain, diagnostic and pathology, and appropriate clinical use of cancer medicines. And as I said, sometimes my cursor can't move. Yeah, there it is. And what we see is that we start with engaging with the country political leadership and cancer stakeholders, assess health systems to identify, country-specific barriers and to safe, effective, and sustainable medicines. We analyze this data and using expertise, local expertise, and then we present it back to the stakeholders to validate the data and determine priority areas, because as you all know, you cannot tackle all the things at once, but over time, you can address all the barriers. So here we identify which one to start with. And of course, co-create country-led projects with partners to align on sustainable solutions to address identifiable priorities. So when we do that assessment, for example, this is just to bring what I was saying into practical context. So this assessment has been done, completed so far, and analyzed and discussed in these 3 countries, El Salvador, Mongolia, and Zambia. But this slide illustrates how the framework works, in practice. Different countries have different priority areas, and that's where Atom Coalition, helps the countries to address. As you see in El Salvador, we are updating guidelines and strengthening chemotherapy efficacy. In Mongolia, we are improving forecasting and diagnostics depending on their priority needs. In Zambia, we have completed major pathology assessments. In Kenya, which is not here, but it's also there, we are testing innovative approaches for targeted therapies. And each country, as I said, has a tailored portfolio based on its priorities. For Uganda, we shall have our own tailored pathway soon because we have just joined lately. Then another pathway, which is another pillar, is healthy financing, which is Atom is not only, as I said, about products or medicines. We also invest heavily in strengthening systems, and including healthy financing systems to identify the gaps, how resources are allocated, the effective planning, and of course, getting funding solutions for sustainable cancer medicine to ensure sustainability. So the Atom Coalition impact to date. So far, we have, as I said, 46 countries, but 9 countries of these 46 Atom countries have engaged in capacity strengthening activities. 37 medicines and 10 diagnostics are now available in these 46 countries through the Atom Coalition access pathways. And many patients, more than 10,000 patients, have benefited through these efforts. And 19 cancer types have available treatment and diagnostic options, including Atom Coalition priority cancers. So as I will show you 45 partners, I'll show you this slide across industry, non-profit, cancer institutions, and many others are part of the Atom Coalition initiative now. This is just a map that really brings a visual to the countries that are involved. I'll give you about 20 seconds or 10 seconds to go through. And I think you can only concentrate on Africa for now. Yeah. And these are the 9 countries now so far that are engaged. The ones I've been talking about. We have El Salvador, Honduras, Ethiopia, Rwanda, Uganda, Zambia, Mongolia, Philippines, and Indonesia. So people may ask, how do you start? How do you start? Where do you come from? Now, my power is off, but let me see where my battery can take me. This slide highlights the general framework currently used by Atom Coalition to support country engagement and implementation. The process, as I said, typically begins with country-level engagement, assessments, followed by, identifying gaps. But this process is so much evolving, and it so much depends on the country context. It is not like a fixed process, but countries start with ministries of health and other key stakeholders. Importantly, as I said, this framework is not rigged. The Atom approach is highly context-driven, recognizing that each country has different health systems, realities, priorities, and capacities. A critical component is that the whole process is the role of a country, involves country focal points and champions who help coordinate stakeholders, drive country ownership, facilitate engagement, and ensure that the implementation remains aligned with the country, national priorities, and local realities. Just to attach some context, As I said, during last year, ATOM and the Ministry of Health in Mongolia have been working to strengthen breast cancer care, updating national guidelines, and advancing multidisciplinary approaches to treatment. This effort, involved improving multidisciplinary care course, a multidisciplinary care course for ASCO, which was held in March. So this is giving you an example of what happens when the gaps are identified. So the impact is already visible. Multidisciplinary teams in remote areas here in Mongolia are reorganizing care delivery, leading to more coordinated and patient-centered services. And in Zambia, you can see we have worked to improve availability of cancer medicines, expanded access to innovative immunotherapy, strengthened the system capacity to use these medicines through the Project ECHO by our partners BMS and Anderson. And in Uganda, as I told you, we launched this in February, and we are continuing to advance the ATOM Coalition Initiative following its launch in February. The country-level assessment to access to oncology medicine and diagnosis has now been completed. And this is a very big milestone for us. We have already, identified some system strength gaps. So the next step we are going to do is validating this assessment with the national stakeholders so that we identify the gaps and then co-design country-led interventions to access to cancer medicines. And of course, it's because of the Ebola we would have our first stakeholder meeting next week. But current discussions are going ahead in enhancing, for example, healthy financing, healthy systems readiness, clinical protocols, diagnostics, and of course, other innovative approach medicines. So these are the partners, very many, and thank you so much.
Thank you very much, Dr. Nakaganda. Thank you very much. So what we see is that your presentation was very comprehensive and highlighting that in order to improve access, we also have to look at quality and also look at country-driven needs. I really like and appreciate what you said. No one solution can fit all. And now we welcome the floor for questions so that we can start our discussion. We have a few questions from the chat. Thank you, Mr. Mapelo. I see that you have already started answering some of them. The first question we had was, how is the choice of intervention decided upon? So this was shared by John Black. So when you talk about access to program or even the complementary services such as awareness, education, navigation, transport facilitation, how is this, how does Max Foundation, and maybe also Dr. Nakaganda, you can share on ATOM. I know you are mentioning how you get about it, but how do you know which intervention is needed for the country that you are approaching and working with?
Mr. Mapelo, do you want to go first? Yes, thanks.
I noticed, sorry, this is John Black. Thanks, both of you, Annette and Elo, for very good presentation. And I noticed you've given an answer to one part of the question. The second part was if there's been any evaluations, maybe in your impact assessment, where you kind of give us an assessment on if it pays off to also pay for transport or to just pay for the medicines, or, when you're choosing between all the different things that you need to actually achieve the end goal of better outcome cancer care, if there's some kind of model to say, actually it pays off to also pay for transport, because sometimes it's difficult to convince someone who is there to provide you with medicine to say, oh, I've given you medicines, or I've helped you with diagnosis, but now you also want me to pay for your transport or for your food, and the problems will just keep accumulating. But I think, for example, from the HIV experience, we noticed that it was actually paying off to do these additional services, sometimes to go ahead and even paying for school fees of the people who needed HIV care. So tell me if this has been looked at in addition to your answer you provided before.
Thank you, John Black, for that, and thank you for highlighting that particular part of that question. We haven't done a scientific survey as yet, but we now know from interacting with the physicians that paying for transportation has really been effective in ensuring completion of treatment. Because about 3 years ago, we had a default rate of up to 22-23%. That's the number of people who are not able to continue on with treatment. The physician will say that they are unreachable, they are lost to follow-up. But that number has since reduced, because when we started implementing the transport support, we actually started by looking at those people who have who are lost to follow-up. Where are they, and what is the main reason? And that actually happened to be the main reason. And when we brought them into that bracket of support, we've seen that number, that percentage of lost to follow-up reduced drastically. I think right now, if you're to do the survey again, it will be about 5% or thereabout of people who are lost to follow-up in the CML treatment program, because we keep following up on them, and this transport support has ensured that they are able to get to the clinic whenever they need to. So we probably may need to do another thorough study to see if that intervention, how impactful it is, and what other interventions need to be done. Because in other jurisdictions where Max Foundation operates, there are various other interventions besides the transport support that we have. Thank you.
Maybe we can also share from the ATOM perspective. How do you select these programs and know what to include in terms to make it comprehensive? I think because Mr. Mapegu has shared, and you also have shared, access to medicine in itself is not enough.
Thank you. Yeah, as I indicated in the slides, the decision on what intervention to take, which one to do, is actually decided by country. It is evidence-based. We do a country-led situation assessment, and then share the results and validate them with the stakeholders of what are the gaps, and then the stakeholders help prioritize which should we address as number one, and then that's where we take it from. So, and then because they also participate in designing actually the interventions, because as you know, cancer interventions are very complex and they cannot be solved by a single solution. So that's the criteria, actually. It's determined by the countries which intervention to do. Thank you.
Thank you very much. Yes, basing it on the context, and I hope the framework is adaptive, because we all know, like Mr. Mapelu was saying, you give access to medication, the next issue arises. People cannot afford to come to the clinic to get the medication. Now you need to include transportation support and education and all of that. So now we are going to move to the next question. This was from Alex Mwakoyo. No, sorry. We are going to start with Christine first before we move to Alex's questions. Christine was sharing that cancer care is generally comprehensive and does not only end at the oncological directed care. She gave an example of brain cancer, where she says somebody might get, let's say they can get their radiation therapy, they can get their surgery, but they need a lot of supportive care like anti-seizure medication. So these supportive medicine that improve their quality of life, is this also something that Max Foundation and ATOM Foundation also considers?
Maybe if I can go with the ATOM, the latest list we have just developed and piloted in Uganda, of course, has supportive medicines for cancer care. As you all know, it is not all about the MABs or the chemotherapy drugs. We need, for example, pre-medications, post-medications, and all these discussed, as I said, in the stakeholders. Stakeholders, for example, a country may be affording, may be able to afford and available of these supportive medicine, and their challenge could be maybe the innovative medicines and maybe targeted therapies. So, but still, it includes that. I don't know about Mr. Mapelo.
Yes.
Yeah, so recently when the Max Foundation started the program to support access to breast cancer medicines, we realized that besides the main medicine, we also needed, the patient also needed hormonal medicine to go with it, aromatase inhibitors. So we have donated medicine, CD46K, for breast cancer, but then the Max Foundation also, through other sources, purchases the hormonal medicine that is required to go along with it. It's a model that is hopefully going to be copied across all other areas of treatment, because it doesn't make sense that you are able to have one part of the treatment and the other part of treatment is left out. So we're trying to have a wholesome approach to it. So we try to get as much cover as possible so that the patient is able to get all kinds of treatment. So we from our example with the breast cancer, we know that if we were to go to other areas and there is more than one, medicine or element required, then we are going to have to do fundraising to make sure that is also made accessible to complete the care. The idea is to have the care as complete as possible.
Thank you very much. I think that brings in the discussion of survivorship, that cancer care goes beyond the treatment and supporting our patients throughout their life cycle after they finish treatment. So next we have a question from Assistant Professor Abino. He is rather asking what requirements are needed for a country such as South Sudan to be able to join in this initiative, like the Atom Countries Initiative, to be a part of that 46 number. And also noting that cancer services are sometimes inaccessible in a country like South Sudan. So maybe we can start with Atom, and then Mr. Mapelo, you can also speak about how Max Foundation expands to include other countries in the great work that they're doing.
Yeah, perfect. Thank you so much. As I said, the Atom Coalition approach is not, a fixed or setting in stone approach, and countries can engage us in the discussions from now, and we see how to approach. But the country selection process starts with the initial phase of engagement, and Atom hopes to support more countries globally, but also different pathways can be accessed by different countries. For example, the NCD Connect is a platform that is also available to South Sudan to make use of the lower cost, good quality medicines and efficient delivery. But I didn't say, our technical advisor Sumi here, who can continue to speak to this, the selection of countries and how Atom goes about it. Yes, Sumi, go on.
Thank you, Annette, and hello, everyone. I'm Sumi Krishnamurthy. I serve as technical lead for country support at the Atom Coalition. And just to briefly explain the country selection process, as Annette mentioned, this is only for the initial phase of operations of Atom. We are now looking at the second phase, so we can definitely try to continue our conversation if South Sudan is interested in this. But for the initial phase, we identified a number of criteria based on epidemiology, based on health systems readiness. So things like doctors, pharmacists per 100,000 patients or per 100,000 population, as well as, our current partners implementing projects and where those geographic footprints exist. And so out of those, we identified the countries where we could have the most impact in terms of feasibility and readiness. So that's the original 46 list. But as Annette mentioned, this is an evolving piece. So great to see that South Sudan is interested, and also to emphasize that our work streams expand globally. So all our tools and all our resources are not only for the 46, but publications and the platform that Annette mentioned is available to all. Thanks.
Thank you. Just to add to that, I think the Max Foundation also follows fairly similar pattern. And like I said, we have presence in about 83 countries around the world. And I think that number keeps expanding. The countries keep getting added to it. And in addition to what Sumitra has said, in the Max Foundation case, we also have, because there's a partnership with the donors, so we also have, discussions with the donors and see which areas will have the best kind of outcomes. So it's just a similar pattern, really, and we hope then that in not too long a time we'll be able to bring on board South Sudan to the list of countries where we have activities in. I know we have activities in the Sudan, in the North Sudan, but I'm sure in a few years then we'll be able to reach out to the South Sudan as well.
Thank you very much. So next question we have is from Luis. Luis was asking, what support does ATOM provide for the pathology laboratory? We know the importance of diagnostics, and this we can also extend it to Mr. Mapelo in terms of Max Foundation. We know you have imatinib, but you need first to test and confirm. And the addition of the CDK4/6, it means you need to test immunohistochemistry. So what support is extended to pathology laboratory in order to improve diagnostics?
Yeah, thank you so much. In terms of diagnostics, we really work with partners to tailor interventions. And this can include, for example, accreditation training, telepathology services, and quality improvement. And in addition, there are diagnostics and devices now available via the NCD Connect. As I said, it gives you more efficient and good quality supplies at a lower cost. And of course, we are working on ATOM countries regarding the biomarkers that are needed to really for care as well. Mr. Mapelo? Yeah, you're on mute.
Yes, sorry. So Max Foundation works with other organizations like Thermo Fisher to make accessible diagnostics for the various cancers. And besides that, we also work closely to make sure that the hospitals that are participating in the program are able to access kits for CML testing and monitoring. So there is an active plan on that, and even going forward, we are working to make sure that we even have the NGS platform supported in the various countries where especially the breast cancer programs are running. So there is that available as well.
Thank you very much. Sumi, did you want to add anything? No, okay. So thank you very much. So one theme we are all getting from this discussion is that the need for context-specific driven innovations. And also, maybe because we have in our presentation today, ATOM and Max Foundation, that have models that have shown to work in terms of access to care. Before I let John Black ask, I just wanted to ask one question. From your perspective, what component of health system readiness is most urgent in most of the African countries in order to push access forward?
Yeah, if I can go fast, and of course in Uganda, we've just completed the analysis, the data collection, and we are going to analyze. But from my experience is that the most important challenge we can start with now are the protocols and guidelines and the criteria, because most of the decisions and interventions and things are not so much well conceived in our setting. Many of them are ad hoc, maybe based on this decision of the significant others. And we have so many who know, the professors, and everyone does it their own way. And for example, there might not be a criteria who benefits which medicine, when and where. So by the end of the day, because of that lack of protocols, harmonized guidelines, and then to our setting, we even waste the limited resources, honestly, that we have. Other things are duplication of services and so many other things all come away because everyone is trying to put down the fire, whoever using a bucket, whoever using maybe a cup. And so for me, in my perspective, but I'm yet to look at the data from my country, that's what I think is a big, big challenge, making sure that the little we have, we make it to good use. And as John Black said, value for everything. Yeah, thank you.
Yeah, similar to that, guidelines, protocols. We also realize that there's a very big need for awareness among the healthcare professionals, because we can have a very good intervention available centrally in one city, and we have practitioners all over the country. It is very fruitful if they would know that exists, and they are able to properly navigate the patients towards where the care is. So awareness is extremely important, and other support from the government, like some of these supports, since they are donated support, they need budgetary support from the government, waivers of taxes and duties. So that's also a very important element of support that will need generally from the government, and also support awareness among the public also, because they are able to then be able to direct the patients accordingly, because we can have a program that has capacity of 1,000 and we only have about 200 people benefiting from it, because people do not know. So awareness both to the public and to the healthcare community, and of course support from the government, the budgetary support from the government, in addition to what Annette has talked about, the guidelines and the protocols.
Thank you very much.
Yeah, there is also what my colleague has put here, that from the Mongolia and Zambia assessment, we saw that actually forecasting and pathology diagnostic is still a big challenge. Of course, sometimes because we don't forecast enough, even when the government commits funds, you find that there will be always recurrent stockouts. And when there are recurrent stockouts, for example, from IDA, then we start procuring medicine through short-term contracts, which you may not be so sure about the quality of medicines, but also the pricing cost of the middleman in between there and everything. And of course, the pathology is diagnostics, a big challenge. I've interacted with oncologists. It is a pain to treat a patient with maybe 6 cycles or 8 cycles over 8 months, only to learn we are treating a different thing. Medicine is wasted, patient has suffered side effects and all that. So thank you so much, Anna, for reminding me about that.
Thank you very much. Sorry, I have to go back to Alex's question. So Dr. Nakaganda, you had brought up in terms of quality. He was talking about the news that Mr. Mapelo had shared, that there was some medication that were of poor quality. Maybe the ingredients were not enough and it was no longer safe, and they have to be pulled back. So the question is, what happens to the patients that have actually used this? And what mechanism or safety mechanism that collaborations like ATOM and MAX can help our ministries and our governments to make sure we have high quality products?
Yeah, of course, this is something I've already alluded to. I've said that actually through the Atom Coalition Initiative and through some of the pathways like NCD Connect, you are very sure of high quality medicines, right from the manufacturer to the patient use, if we actually embrace such innovations and interventions, because it comes in to address such needs. From my country, Uganda, I don't know, it may not be too much like in Kenya because 90% of the cancer medicines are centralized under the disease hospital, Uganda Cancer Institute for procurement, and it is being using IDA, I know. So through such systems, you are assured honestly of high quality medicines and procuring medicines in a big, bulk that is going to lower the cost. Yeah, that's what I can say.
Yeah, for the Max Foundation, quality is at the heart of the programs, and we ensure that there is thorough checks. We have a very vibrant quality control department that thoroughly checks on the every drug that is donated or procured by the Max Foundation to be sent to the various countries. So that particular area is not second guessed. It's thoroughly looked at. This particular unfortunate situation, I'm sure there's a recall policy from the various manufacturers, and I'm sure they should be able to effect that and probably have an alternative treatment given to the patients according to what the recall policy is, because it's one thing to remove the medicines from the shelves, but another thing altogether to make sure that those who have been exposed to the medicine are taken care of, monitored, and treated accordingly. So I'm sure the Pharmacy and Poisons Board will be able to follow through to make sure that they're not only removing it out of the shelves, but also enforcing the mandatory care that the manufacturer has committed themselves to in making sure that the patients who have been exposed are properly taken care of, to make sure that there's no toxicity or any undue effect from using the medicines that have been said to be defective. But for the Max Foundation, we have a thorough quality control system that ensures that the end user is getting access to properly quality controlled products. Thank you.
Thank you very much. John Black, please proceed with your question.
Yes, thanks. The discussion is interesting. There's a few things that I think I've touched on the question that I'm going to ask, but I'll give it still. I actually have two. One is for you, Annette, and it's about health insurance. I did not see a lot of that being discussed, and there was a discussion of sustainable, access, and I think looking at where the money comes from, especially national health insurance systems, if they are there. In Uganda, we still have a bit of that, but in Kenya, there was a bit of discussion on that as well. But there are also community financing mechanisms. There's a lot of private ones in Uganda, and usually they don't want to cover cancer medicines because of the cost. So I think if you're engaging the Ministry of Health, these are also important stakeholders. So I want you to comment a bit on how that is being done. There are even some saving mechanisms from like MTN, IO, something like that. I don't know if that group has been reached, because I think that is one way to make things more sustainable. And then the other question is actually for both of you. It seems like the programs have been very well, nicely thought through. And my question is, what is missing now? Why doesn't every patient get access to cancer medicines? Is it that we need to lobby more? Is it that we need to do social media campaigns? Is it that we need to optimize so that the medicines don't get wasted on patients who have a different diagnosis? Could you comment on what is the missing piece to ensure that everyone has access to the treatment that they need? Over.
Yeah, thank you so much. That's a really very good question. Our situation analysis actually assesses the cost and the financing models, including health insurance. I know this applies so much to countries like Kenya, but in Uganda, as you know, the way our government funds cancer care is different. Of course, we pay taxes, but it gives free health care to all patients in Uganda. But our assessment now in healthy financing is undergoing. It is extended. It started a bit late with a general situation analysis, but it is also trying to add to really find out different pathways to meet the costs. Of course, as you may all know, there is no country, whether developed countries, that gives a full package for cancer treatment. You know, sometimes they have limits of what you can access freely, and then extra can be paid, the different tier and so on. But we are now working on to see that actually with the ATOM, reducing the out-of-pocket payments, the financial toxicity measures, like you said, discussing the health insurance. We are looking at how to mobilize capital for infrastructure upgrades and policies. Sometimes it's all about to do with the policies, how they are aligned to the country needs to endure sort of affordability and cost effectiveness. So as you know, you can actually spend all the money in the world, but unless you make some smart investments. So this is the capacity, I must be honest, that we have not had so much to do with the healthy financing models for health care in our setting. And actually, ATOM comes in with experts in healthy financing. And I want Anna to speak to this. Now that, Anna, do you want to speak to this now that Saban is not here about this? Even me, myself, I'm not so familiar with monies and funds and funding mechanisms, but Anna can help. Anna is also a technical advisor with the ATOM Coalition.
Yeah, so rather than speaking about health financing, which, you know, it's a topic that I'm not an expert, but I wanted to touch on what John Black said about what can we do? And I think that there is a big piece of advocacy that is missing, that you see a lot of cancer advocates focusing on, you know, early detection, awareness, and other things. And you don't see really good or a lot of activity in that area, in health financing, in trying to understand, you know, health technology assessment and so on. You start seeing some, for example, in Kenya. I think that there is a big focus on that area. And also in Indonesia, they started to just form breast cancer, I think they call it breast cancer forum, that will also focus on these things, on access, but from the financial aspect. So, you know, it is a focus of the ATOM Coalition. We don't have our health financing advisor here, but we do conduct health financing assessments to see where we can do what are the areas that are actionable, but really also there is in my opinion, an important task to be done in the advocacy field, right? In providing the tools so cancer advocates can really also advocate about that. And thanks for the question. I think it's very relevant, and you're so right.
Thank you. So I'm going to ask Misha to ask a question before we address the second question, which was these modules are working, why still access is an issue in our settings. So Mishka, please welcome.
Thank you, Sarah, and great to hear these great talks, and good to see you all. I guess my question is somewhat related to that second question. I'm interested if you could both speak a little bit to how these initiatives tie into the National Cancer Planning pathway within the countries that you're engaged in. And you've mentioned and described very well how you engage right from the start with ministries of health and engage with those stakeholders as well as communities as you build the programs. And then topics like this, like health financing, you know, sort of longer term access, the things that Anna had put in the chat around pathology and forecasting. do you have a pathway to share that information back to the ministry as they then are either designing for the first time or rewriting a national cancer plan? Off the top of my head, I don't know for El Salvador and Mongolia. For Adam, I know Zambia has at least 1 or 2 iterations of their cancer plan. So just curious if you could speak a little bit to that, in terms of that sustainability for some of the programs that you all lead.
Yeah, thank you so much, Mishka. Yes, because I conducted the situation analysis myself, and the National Cancer Control Plan is one of the key documents that I reviewed, and making sure that the situation, because it started with a literature review and then filling the gaps with the in-depth interviews. So I made sure that the priorities that were set, I know that, for example, the Uganda National Cancer Control Plan was written some years ago, but they are reflected. And now during the stakeholder engagement meetings, which are yet to happen, we bring that refresher that according to the NCCP, these are the priorities. And from
Yeah, the work of the Marks Foundation, I'll just give an example of Kenya, started some 20 years ago. But only 5 years ago is when we started working closely with the government, with the National Cancer Control Program. And we have been co-designing the program with them. And it's out of that partnership, very close partnership we have with NCCP, that the Marks Foundation's work expanded from just one city, that is Nairobi, to various other cities around the country, so that now it becomes part and parcel of the National Cancer Control strategy. And that has also been helpful in the sense that when the National Cancer Control Program was designing reimbursement packages for the social health insurance, they put in consideration some of the diagnostics that are, and monitoring tests that are required by the various recipients of the donated program by the Marks Foundation, so as to try as much as possible to have that insurance taken care of, because in absence of which then the patients will have to pay out of pocket. So because of that partnership and because of that collaboration between the National Cancer Control Program and the Marks Foundation, we've seen most of the work done by the Marks Foundation being put in the strategic plan of the NCCP.
Thank you very much. We now only have 5 minutes left. I know it is a very rich discussion, but we have to close. So thank you very much for our panel and for everybody who joined in. And I think from today's discussion, what we can appreciate is that access to cancer treatment in Africa is comprehensive. It's not only about medicine, but also about strengthening the safety, talking about high quality and safe medication, equitable, talking about universal coverage and insurance, and of course, sustainability of the models and having our government supporting them. So thank you very much. I know we might still have more questions. Please reach out to Dr. Nakaganda, to Mr. Mapelu, they're all available. And right now, we would like to invite the ECHO team for closing comments before we end the session. Thank you.
So thank you very much, Dr. Sarah. Yeah, indeed, it was a very rich discussion. And I know we've all learned one thing or two. So I'd like to thank our speakers for today, Dr. Nakaganda and Mr. Mapelu. Thank you very much for speaking to us today. So we are going to be posting this recording on our YouTube channel, maybe in a week or so. Again, if you missed anything or you need to revisit, you can always visit our Africa Cancer Research and Control Echo YouTube channel, and you'll be able to catch up with the recording. So this is a continuing series, and our next session will be held in June, that is next month, the last Thursday. Please, we hope that you'll be able to join us so that we can continue running and advancing cancer control in Africa. So we have a steering committee that has been driving this, and the chairperson is here. So I can invite him to make a few remarks as we close. So Dr. Bunya.
All right, thank you very much, Charles and team as well. I don't want to dwell so much on what was discussed, but as we come to the close of today's echo session, I would like to sincerely thank our moderator, Dr. Sarah Nyagabona, our case presenter, Mr. Elo Mapelu, and our didactic presenter, Dr. Annette Nakaganda, for an insightful and impactful discussion. And today's session has highlighted the urgent need for innovation, collaboration, and equitable access to cancer care across the continent. So we've had the importance of strengthening health systems, improving access to oncology medicines, supporting patient-centered care, and building sustainable partnerships that can transform cancer outcomes in Africa. So, I mean, definitely the discussions for today reminds us that advancing cancer treatment in Africa requires a collective effort for healthcare professionals, researchers, patient advocates, policymakers, and I can stress on the point on patient advocates, which has been mentioned a couple of times, development partners, and also the communities. So through this platform, such as Project ECHO, we continue to create opportunities for shared learning, mentorship, and cross-country collaboration that ultimately improve patient care. So on behalf of the Africa Cancer Research and Control ECHO program, and also the steering committee who have been able to have this session in place, we thank everyone who joined and actively participated in today's session. Your engagement, questions, and shared experiences continue to strengthen this growing community of practice. So we encourage everyone to continue the conversations beyond today, apply the lessons learned with your respective settings, and remain committed to improving access to quality cancer care across Africa. So thank you once again, and we look forward to seeing you to our next ACRC ECHO session. Stay safe, stay engaged, and continue being champions for cancer care and control in Africa as well. So thank you, Charles. Thank you, everybody else, and have a good evening.
Thank you and bye.
Thank you.